Okay, thank you.
Welcome, and thank you for joining us today for the meeting of the New York City Health and Hospital Strategic Planning Committee. Today's meeting is officially called to order. Quorum has not been established, therefore, we will defer the adoption of the minutes of the Strategic Planning Committee meeting held on April 12, 2021. We are going to go to our second agenda item, and this is Dr. Wei, who's going to provide us an update on the system dashboard. Dr. Wei?
All right, thank you, Mr. Chair. And so following our normal routine, we're going to start with external landscapes. I'm going to turn it over to Deb.
Hello, everyone. Deborah Brown, Senior Vice President for External and Regulatory Affairs. It is a pleasure to see people in person. Very briefly, talking about what's going on externally, that of course impacts what we do. As we look at the Biden administration and people taking their seats, we start to see the beginning of their regulatory priorities. Really what the steps they've taken thus far are to essentially do away with things that came about in the past administration towards a more progressive vision of healthcare provision. Certainly something that is beneficial for us. One of the things that we will be doing in the coming months is informing and educating the federal administration on our special populations proposal. We think that is something that, certainly the city and the state will be working on, but the feds as well will be a supportive and important partner when we get to that point. In terms of legislation, the big thing right now, of course, Congress is coming back this week. The big issue is the infrastructure package. Unfortunately, hospitals are not a part of infrastructure at this point, other than perhaps the VA. That is, something that we and many, many others have continued to advocate for, and we will continue to seek infrastructure and capital project support. It's very important. The good news is that our quote unquote earmark proposals are progressing for at least 4 of our facilities: Jacoby, Elmhurst, Queens, and Coney Island. We've had tremendous support from the delegation. We are very, very grateful to our congressional leaders, up to Leader Schumer, who have come out for a number of events at our facilities in support of these initiatives. And that, I think, will manage federal. On the state level, the Albany session has concluded. There was an increase of bills this year relative to last year. We have identified some areas of significant concern or interest for us. Most of the bills that were mostly important related to staffing provisions. We've discussed those previously. This is a situation in which H&H was very well positioned by our work prior to the development of these legislative mandates. SNF transparency, something of course we're very supportive of. We're working with a number of stakeholders on the creation of a suicide prevention hotline, a 988 number that is certainly not only our initiative, but we are pleased to be a part of it. The big priorities next year already are indigent care pool restructuring. That is unfortunately something that did not happen this year, as well as telehealth parity. Good news on the budget side is that we averted about $250 million of cuts. We've discussed that previously, and we are working with the state and a number of other stakeholders on their ongoing state waiver activity. Citywide side, it was a long process to get to some results on the citywide elections. We are pleased that we are here. We look forward to working with the incoming elected officials, assuming that the Democratic nominees continue to prevail as we get to the general election. And the city budget has been adopted, and I know John Olberg and his team are doing an analysis. That's the broad strokes.
Thank you.
Of course.
Any questions? Frida can ask questions, is that correct? Yeah. Frida, do you have it?
Hi, Frida.
Frida, do you have any questions?
I do not, Vinny. Thank you.
Thank you,
Deb.
Frida. Okay,
Thanks,
thank
Frida.
you. Thank you for a wonderful. And I just want to say that, this report is definitely kind of feels good, because it seems that things are falling in place, and it looks that things are going to at least move in the right direction. So let's hope. And I really like how you're breaking it down and ensuring that you're able to communicate our special population to the new individuals in Washington, D.C., which I think is very important, and also the participation of Leader Schumer and Senator Gillibrand and AOC and all of those representatives. So I'm glad that these things seem to be going. So thank you for leading those efforts and to make sure that Health and Hospital is able to be there at the table in ensuring that the resources that we need are available.
It is our pleasure, and we could not ask for better representation from our leaders.
Thank you. Dr. Wade?
All right, thank you so much, Deb. And so just to orient the board, we are talking about fiscal year 21, quarter 3. This is January 1st, 2021 to March 31st, 2021. And we organized our report with positive trends, negative trends, and stable trends. And we also, at Mr. Chair's recommendation, organized them around our strategic pillars. So you'll see, first one is quality and outcomes. And this is the follow-up appointment kept within 30 days after behavioral health discharge, up from 37% to 55.7%, with a target of 66. And so a lot of credit goes to Dr. Allen, Dr. Charles Barron, Dr. Omar Fatal, and the Office of Behavioral Health. I know Dr. Fatal is working on a PI project around this very thing and integrating direct feedback to the providers to make the calls, as well as telemedicine here. So we hope to see this continue to go up. Under the care experience strategic pillar, our ambulatory care recommend providers office continues to trend upwards and is painfully close to our target of 87%. So, it's at 86.97, up from 82.88. So great job in Gotham and Dr. Ted Long's office to continue to meet and exceed patients' expectations there. One of the real bright spots for us over the last 2 years is MyChart activations. Remember when we were talking about trying to get to 20%, and we blew through that first goal of 30% and 50%. Now we're trying to reach almost Kaiser levels at 75%. So we're at 66 currently, up from 55%. A lot of hard work by Kim Mendez, EITS, along with ambulatory care and quality and safety on this target.
Sure. These average figures, you take all hospitals?
Yes, it's across the system, yes. Okay, so moving on, continuing with positive trends, and I'll turn this over to Krista Olson from our finance team, the financial sustainability pillar.
Hi, good morning. The first indicator here is the patient care revenue over expenses. We've improved from 72.6% to 74% over the well over the 60% target. This is primarily due to both the complexity of the COVID patients and the increase in revenue associated with them, as well as the revenue initiatives that we've spoken about previously. The second indicator is the percent of uninsured patients enrolled in health insurance coverage or financial assistance. This is also up from 58% to 72%. The total AR days per month is 60 days, down from 62.6, which is a positive trend, but still over the target of 45 days, which is the industry standard. And finally, post-acute care total AR days of over 12 months has gone down from 51 days to 48.2 days, below the target of 55 days.
Thank you, Krista. Moving to our access to care strategic pillar, number of e-consults continues to go up, 82,226, up from 71,793. I think we do need to adjust the target here because it's almost double at this point. NYC Care sort of continued to move along in the background during the pandemic, but is now live across all 5 boroughs. Continue to exceed enrollment targets, 65,788, up from 46,460 prior quarter. For our culture of safety strategic pillar, total wellness encounters, and just wellness encounters encompass one-on-one debriefs, group debriefs, wellness rounds in the clinical spaces. So across the system, we had 916 wellness encounters, up from 737. Any questions on the positive trends?
I just had a question. In the areas where you increased by 30%, 40%, is there a special emphasis placed on those areas? Like behavioral health, I know is one that all hospitals struggle with.
Mhm.
It's an amazing figure, so I'm just curious.
Yeah, so anything on this system dashboard is going to get a lot of attention since it is the system dashboard. So yes, they're all prioritized, and there was a reason we selected these projects. I think we're still seeing kind of how things are going to settle coming out of the pandemic. A lot of things did go down, including this follow-up, 30-day follow-up. And so some of it is just getting back to where we were and continuing to push forward. Things like my chart and wellness encounters, certainly prioritized through the pandemic and went up. So we might see wellness encounters come down a bit when people don't need as much emotional, psychological support. So I think the short answer is yes, these are all prioritized metrics because they're in our system dashboard. And two is there is some opportunity to make big changes coming out of the pandemic.
Frida, any question both on the financial or any of the positive trends? Okay, thank you.
Okay. Now I'm going to move to the opportunities for improvement or the negative trends. Our percent left without being seen from our emergency departments bumped back up from 1.8% to 3%. We'll say this is still below our target of 4%, which is a very aggressive target for a public healthcare system. And we attribute this to a little bit of the return of volume to our emergency departments. Number two, our post-acute care all-cause hospitalization rates bumped up from 1.55 per 1,000 care days to 1.85 per 1,000 care days. We think some of this is affected by COVID, which is still very much a threat across the healthcare landscape. For care experience, our inpatient care dropped a little bit from 66.65% to 64.96%. It's very close to our 66.3% target. This is one of those where we were very pleasantly surprised that even with all the stresses that COVID-19 brought to our systems, our care experience numbers shot up last year. We don't know if this is some of the appreciation of New York City and our communities for everything that we did, and a little bit of return to mean as we come out of the pandemic. But it's something we're paying very close attention to and continue to work with Plaintree for person-centered certification, as well as Pascani to really, try to hold those numbers at the records.
But wait,
Yes.
If you look at your note, this is higher than the same the rating at the same time last year, just pre-COVID. So definitely, we're seeing still some of that.
Yep. Unique primary care patients trended down from 376,558 to 370,878. I think we're hoping to see this number settle and start to go back up now that we're encouraging and communicating that it is safe to come back to our clinics and to our hospitals. Any questions on the negative trends?
Does this include other patients? This is probably for Ted. Does this include the televisits or patients who go and have those kind of encounters?
I do believe they are all encounter types, visit types, but I can confirm that. I believe that it does include the phone calls and the video visits.
It says all encounter types.
Yeah.
One question that I have following up on that is that we have TBD on the goal, the target. Do we expect to put a number, or we think that it's going to continue to be?
No, by next quarter, we should have one. We've been working with ambulatory care, Dr. Hannah Jackson and Ted Long. I think it was a lot of kind of what is the true kind of data governance definition of this. And so it's kind of fluctuated, but we're confident now this is the definition that we're going with. And so now that we know what the numbers actually look like, we can set a realistic goal. So
Thank you.
expect it by next quarter.
You know what I was surprised by, Eric, was the ED time, because at Quampi, we've seen hospitals, one after another coming in, and they really focused on ED all the time.
Mhm.
Maybe we're just gonna see that a little further out.
Yeah. No, I think definitely want us to hold under 4%. But it is, right, when people are too scared to come to the hospitals, right, there was a lot of our EDGs would argue, we had excellent staffing, right, for the number of patients that were coming in. And so got a lot more nursing care, you got a lot more doctor attention. But as the numbers creep back up to where they were pre-pandemic, they're feeling the stresses again. But I will say a lot of our hospitals, out of the necessity of COVID-19, worked really hard on that transition from admitted patient in the ED to upstairs. So for right now at Bellevue, it's about 1 hour boarding time. I just went back to Bellevue to do shifts after being gone for 2 years, and it is a palpable difference feeling when you have all the care spaces in the ED dedicated to active ED patients. So Elmhurst has done work on this. Kings County did a lot of work. They presented at their last Quampi. Everyone's worked on, right, how do we get patients that are admitted upstairs faster? And that plays a big, because if I don't have room to put anybody into or a chair to put somebody into, then they wait in the waiting room and then they end up leaving. So,
Thank you.
okay. So I'm going to move to page 18 in the report, and these are steady trends and new highlights. So quality and outcomes, hemoglobin A1C less than 8, 60.7% from 61%. I think we're seeing this stabilize, and I know Dr. Nicola Davis has talked about this at other forums before, but a lot of attention on getting people back in so we can get that point of care finger sticks and get their most recent hemoglobin A1C into the EMR, getting them reestablished with chronic disease management with their medications. For integration of biomedical devices, so this is a new measure for this quarter. We exceeded the target, so ahead of what we expected to do this quarter at 103%. And if you look down at footnote 2, current performance at 103 is 304 devices this past quarter over the goal of 294. And then the overall is 294 over, hold on. We're about 12% of the overall project progress. Yeah. For financial sustainability, Krista, you want to talk to these two?
Sure. The next indicator is the percent of Metro Plus medical spend at NYC Health and Hospitals. This has remained relatively steady, going from 39.1% to 38.8%, under the target of 45%. We'll continue to work on that. And then the next indicator is a new measure, data center migration progress. It's at 90% of meeting the project deliverables for calendar year 21, quarter 1. Completion of 100% of the deliverables is the quarterly goal.
I have a question. What that measurement about the percentage of Metro Plus medical spend in New York City Health and Hospital, is that like around 62% is in other hospitals?
Right, it does, that's correct. It includes like other types of spend as well, like laboratory. It includes, I believe we exclude pharmacy for this particular measure. It includes long-term care, DME, things like that though. So there is a high proportion of services in addition to what we consider our core services here. The target is 45%, however, and we have recently implemented a new patient retention dashboard which should enable the facilities and primary care providers and ourselves to just better measure and manage. So we are hoping to make a focused effort on that over the next year.
I think the issue is one of retention. I think Metro Plus does pretty well connecting new patients with health and hospital providers. I think the issue is one of retention. I think Metro Plus does pretty well connecting new patients with H&H providers. But then the issue is one of retaining them once they become once they've linked up with H&H providers.
Is there analysis of where normally these individuals will go? Like, for example, particularly the ones that leave once they get connected to health and hospital and then go to other providers. Do we have any knowledge which one is the one that kind of attracts them the most?
So this dashboard is our means to be able to really inform the answer to that question. Just a note that the overall universe that we're talking about here includes both our primary care patients as well as our community providers and their patients. So it includes both our H&H patients who are perhaps going elsewhere for specialty or emergency care. Another note is that this includes urgent care, and particularly with COVID, a number of patients went to other urgent care providers for COVID testing, obviously, as well as our own. But there's a lot, that's included here, and it's definitely a number of different areas that we're hoping to look at over the next year.
Okay, so I'm going to bring us to page 19 in the report now. And this was a series of multiple meetings and hard work of many people, including Mr. Chair and Jose, Dr. Pagan, and others on the board. So thank you so much for helping us think this through. Really, a lot of credit goes to the Equity and Access Council, Dr. Natalia Sineas, Dr. Nicola Davis, as well as Yvette Villanueva and her team, Matilde Roman. So the three racial and social equity measures that are being added to the dashboard this time, number one, the percent of new physician hires being underrepresented minorities, and currently working through some of the data governance to get that metric. I know we were trying really hard to get it for this meeting, but we will have it for the next one. Number two is the percent of chronic disease dashboard. Oh, and on that first one is Drs. Michelle Allen and Donnie Bell, who are doing a lot of great work around pathways and other opportunities to engage students as young as high school, but all through medical school, residency, fellowship, and so forth to bring more underrepresented minorities, as well as just our hiring practices and paying attention to what these numbers look like. Number two, percent of chronic disease dashboards with race, ethnicity, and language data. So this is very much aligned with Equity and Access Council and Dr. Nicola Davis's area over chronic diseases. There are 6 dashboards that she's working to integrate this in. Target is 100%. We're currently at 0% since we just selected this as a target. And the last one, percent of total procurement spend on MWBE. Also working with Danielle Tabari, the capital committee of the board, to come up with the correct kind of calculation and definition for the data here. We expect to have that at the next meeting. Any questions? And then on page 20, these are the COVID-specific metrics that we've added to the dashboard and modified based on the feedback from the board. You can see total number of COVID-19 tests administered went up from October to December to January to March by almost 200,000, 184,000. Total number of positive tests also went up. Remind you that this was really the middle of the long but flatter curve of the second wave in New York City, and so this makes sense that there's more positive tests in this quarter, and then post-acute care COVID infection rate also went up, and that's the second wave was happening at that time. For vaccine doses, 366,448 first doses, 303,568 second doses. In our bed occupancy numbers, it did get tighter in the second wave, and that was a lot of the fact that in the first wave, many of the non-COVID patients and demand went away. In the second wave, they stayed almost exactly at pre-pandemic levels, so all the COVID patients in the second wave were extra on top of that volume. Any questions on the COVID?
I do have a couple of questions.
Yeah.
That you may not be able. Even though this is as March this year, do you have any information on how we are doing currently? Again, if you don't have data.
Yeah, so I love seeing our Sentinel surveillance dashboard with single digits for ICU COVID patients. It's fluctuated between 5 and 10. And just compared to where we were last March or even in the second wave, that's an amazing number. We're in about the 30s for total number of COVID positive patients admitted to the hospital. Our positivity has actually been a little bit lower than the city surveillance, and so most recently about 0.35% positive for all the tests that we're doing at H&H sites. The city has reached a nadir at about 0.5% positivity, but as of this morning, it was 1.12%. So the Delta variant is definitely causing an increase in cases across the country, and New York City is no different.
And actually, that was going to be my second question, but before we go there, I see that as of March 31st, we have over 366 first doses. You know where the number are now? So we're in the 500,000, did we break?
So we definitely celebrated our millionth dose. I think that was about a month ago now. So certainly, yeah. So we're getting close to 1.5. So these numbers should be closer to 750 each.
Okay. And the last one is about the Delta variant. Are we keeping track of them separately? I know that maybe we are not collecting in dashboard, but if there's something that we should be kind of thinking about it from the strategic perspective. I know that this is something that changes, and particularly with the variants. But is there something that you think would be good to know?
Yes. So we are definitely following it very closely. Kenra Ford is leading a lot of this effort in terms of she was pushing a public health lab and then now our own labs to be able to do the variant identification. So basically typing the virus genome. And we continue to have weekly meetings on Tuesday mornings where our epidemiologists walk us through what does the data mean. And so we are tracking all the different variants, what percentage of positivity it is amongst our patients that were testing positive, as well as across the city. So definitely something that we're paying very close attention to. It is scary seeing what's happening in some of the lower vaccinated regions of the U.S. that are turning into mini hotspots. Again, we'll say that New York City is higher than a lot of these states that are seeing the hotspots. But that's why we expected the positivity to go up a little with the Delta variant because we're not at 100%, anywhere near 100%. But it's hard to see with the data that's coming out about the Pfizer and Moderna vaccine's effectiveness, even against the Delta, that we would see a surge, anything like the first or second wave at this point. But that being said, the Delta variant didn't exist before it had hosts to jump to. So the longer we let this virus mutate, the scarier that prospect becomes. I don't know, Michelle, if you wanted to add anything to that.
No, just to reinforce, Denny, that we are doing ongoing surveillance of all of our admissions in terms of the genomic variation. And as Eric said, it's those areas with population that's not been vaccinated are suffering the most, and I think for New York City, that might be Staten Island at this point.
We have lower vaccination.
Have lower vaccination, higher prevalence of the Delta virus. The thing with the vaccinations, just what I'm understanding, is that the vaccine actually prevents hospitalizations and illness. So you may be positive for the virus, but you don't suffer as much if you've been vaccinated with the vaccines that we have available now. That's the extent of my knowledge.
But you are contagious. That means you have the virus, you don't get sick, but you can actually pass it on to other people.
And you may have a mild form of the illness, but in terms of, so when we look at COVID, we look at not just infection rates, but illness and hospitalization. So it's a continuum. You can either just have the virus and no illness, virus plus illness, virus plus severe illness, which leads to hospitalization. And then, of course, there's always a mortality rate. So there are several metrics that we can follow.
Channeling my inner Dr. Long, just to note that because Staten Island is experiencing that problem, there's been an aggregation of resources there, both for testing and for vaccination, again, to try to counter that problem.
So you have to pull more resources to go.
Yeah.
It's very, very
Yeah.
important. And question, I know that in other meetings we have discussed our vaccination rate of staff. How are we doing with that?
Well, we can get back to you on that.
Okay, yeah.
Just to give you the accurate numbers as of today. It comes out every day. Dashboards. It's certainly available, but I'm not sure.
Yep. And just a clarification of the comment that you made, Dr. Wade. You are going to be able to identify all the different types of variants of our patients that we test, even on the T2 sites.
Yes.
Yeah. So
Yeah.
we will
And-
say which one are.
Yeah. And it is a sample, right? They can't test every single.
Oh, they are not testing every.
Yeah,
individual.
so it is still a sample, but the sample number keeps going higher and higher as the capacity to do the testing goes up and up.
Is that it?
No.
Thank you.
Okay, and then the last 2 pages of the report is just the legend with the definitions for each metric, so that might be interesting for the new ones. And then the last page is the actual system dashboard with the red, yellow, and green that shows kind of the target, the variance of target, prior period, and prior year, same period, but we did cover every metric here in the prior slides.
And the 15, column 15, the usage, the 12-month running numbers. Now that's quarterly, is that correct?
Yeah.
Yes.
Sorry, I need to check my glasses again.
Yes, yes, yeah.
I'm having a hard time to read
Yeah,
now.
They are all quarterly now.
Yeah, all correct. But it has TBD on that, on the target, is that correct? Number 15?
Number 15.
I
Yes,
cannot read.
yes, that was the one that we're gonna set apart.
You are going to check.
Yeah.
But you still have it.
Oh, a variance.
you
I'll
it
have to
red.
check. I'll have to check that. Yeah,
So you will have to check it against
Yes,
something to
yes.
make it
correct.
red. Thank you. Still everything fits in one page.
Yes.
So
It's
that's-
Yeah, small.
it's getting smaller and smaller.
Okay.
Right.
Still fits in one page. All right, is there any other questions?
I was
Maybe
surprised
Deborah?
that Staten Island has such a low vaccinated population. I don't know. I mean, I guess you don't think of Staten Island. That's not what first comes to mind. There is.
So there are a couple of populations that are when we were tracking prevalence of the virus, a couple of hotspots, Staten Island, as well as along like the Rockaways, particular neighborhoods in the Rockaways that were hard hit.
Any other questions? I guess if there are no other questions, Big vision.
Early. Are you big me today?
Oh, gosh. Thank you, Eddie.
Yeah, great to see you.
Thank you for